Brown spots on your skin can be just a freckle, a sunspot, or an age spot, and sometimes they can be skin cancer called melanoma. Skin spots are areas where pigments such as melanin or iron accumulate. They can be benign or dangerous because sun exposure, hormones, and skin inflammation are common, and melanoma often missed early when it looks like just a brown spot. That's why I will tell you top 7 causes of brown spots on your skin, their hallmarks, diagnosis, and treatment. The first and most common cause of brown spot is solar lentigo. It is also called sunspot or age spot. It is caused by ultraviolet light, which stimulates melanocytes and keratinocytes, and they release extra melanin into the skin. This is cell activation, it's not disease, no atypical or no cancerous cell growth. Hallmark of this condition is flat, well-defined, uniform dark brown spots, usually up to 20 millimeters, often multiple, common on face, forehead, hands, shoulders, and upper back. It's very common. It affects almost 90% of people after the age of 50, especially those with fair skin. They may look like freckles, but freckles fade in winter and smaller and start in childhood, and age spot more common in advanced age. It may look like melasma, but melasmas are larger and often hormonal, so hormones trigger them, and they have more irregular edges. Treatment of age spot is to prevent new spots using daily sunscreens SPF 50 or more, mequinol 2% and tretinoin 0.01% solutions. Also cryotherapy, laser therapy, chemical peels. They have variable success but still effective. The second most common cause of brown spot is post-inflammatory hyperpigmentation. It is usually caused by skin injury, acne, eczema, rash, burns, or any inflammation on the skin. This inflammation activates melanocytes to produce melanin, and which drops deeper into the skin. And hallmark of post-inflammatory hyperpigmentation is that they are flat, brown to dark patches at the site of prior infection, and some of them fades within months, others stay for life. Depends on pigment depth, but they're more persistent in darker skin tones. Prevalence varies, but up to 65% of people with inflammatory skin condition develop post-inflammatory hyperpigmentation. We should differentiate this condition from melasma. Melasma is more symmetrical and hormone related, not post-injury, and we should differentiate it from solar lentigo. Lentigo is directly linked to sun and not to healing skin lesions. Treatment of post-inflammatory hyperpigmentation is topical retinoids like tretinoin or adapalene. At night, it speeds cell turnover, and other like acid and niacinamide 4 to 5% in the morning is effective. Also, it reduces melanin transfer. The third most common cause is melasma. Melasma is caused by hormones and light stimulation of melanocytes, and they produce excess melanin. Hallmark of melasma is that it's blotchy brown patches on the face, map-like borders. They can be sharp, sometimes they can be blurred, and it's common in women aged 20 to 50. 70% of pregnant women have these melasmas, and it is called mask of pregnancy. More common in Asians, Hispanics, and Middle East populations. We should differentiate it from post-inflammatory hyperpigmentation because in case of hyperpigmentation, it follows inflammation, not hormonal cycles. We should differentiate it from solar lentigo. Solar lentigos are smaller ones and discrete spots, and this is larger. And treatment is triple combination creams, hydroquinone 4%, plus tretinoin 0.05%, and fluocinolone 0.01%. nightly for 8 to 12 weeks. And fourth is seborrheic keratosis. Seborrheic keratosis is a proliferation of keratinocytes. It's benign condition and not directly linked to sun damage. They are waxy, wart-like or velvety surface, brown or black, anywhere except palms and soles, and most common in older adults after 50. 90% of 60 have at least one seborrheic keratosis. We should differentiate it from melanoma. Melanoma has more irregular, evolving shapes. We should differentiate it from pigmented basal cell carcinoma. They have pearly edges and they may ulcerate. And treatment of seborrheic keratosis is cryotherapy, curettage, or electrodissection. Biopsy is needed if it's fast-growing or irregular to rule out cancer. And fifth most common cause is atypical navy or just navy moles. Navies are melanocytes when grow in cluster due to genetics, UV exposure, or normal skin development. Most of navy are benign. Usually they are small, even color, smooth edges, symmetric, and stable. Atypical moles are different. Atypical moles carry some risks. Atypical moles are larger, more than 6 millimeters. They have more irregular border, and they varied in colors. Nearly all adults have moles. Atypical nevi is in around 80% of population. We should differentiate it from seborrheic keratosis. Seborrheic keratosis more rough and stuck on look. And ABCD rules, which are red flags, and when biopsy is needed or when more attention is required, is when moles are asymmetrical, it's A. When they have border irregularity, it's B. When they have color variation, it's C. When they have larger diameter, it's D, more than 6 millimeters. And when they evolving, when they change in size, shape, or color, or they have symptoms, for example, itching or bleeding. And the sixth most common cause is melanoma and lentigo maligna. Lentigo maligna is subtype of melanoma, and melanoma is skin cancer. Melanoma is deadly skin cancer. Melanoma usually have irregular shape, color, growth, may arise from normal skin or mole. Lentigo maligna is subtype of melanoma. It is also called melanoma in situ, grows slowly in sun-exposed areas, usually on facial skin, usually in elderly. We should differentiate it from atypical navy. Moles and navies usually stable over time. Solar lentigo has uniform color and sharp borders, while melanomas have color variation inside the lesion and they have irregular borders. Treatment is surgical, usually, especially for lentigo maligna, and surgical excision is usually enough, while melanoma requires more combined and complex treatment in most cases. Surgery is important, also immunotherapy, targeted therapy for advanced stages. Prognosis is very good in case of lentigo maligna, but in case of melanoma, it's still a huge challenge for humanity. And seventh condition is acanthosis nigricans. Acanthosis nigricans is excess growth factors when stimulates the skin, epidermis and dermis, especially when there's insulin resistance. Insulin-like growth factor is important player here. And skin is thickened, velvety, brownish, usually in skin folds, back of the neck, armpits, groin, or under the breast, around navel, sometimes elbows, knees, or hips. It's most common in people with obesity, prediabetes, diabetes, polycystic ovary syndrome, and affects around 30% of general population, and higher in metabolic syndrome. We should differentiate it from fungal infection. It can look like tiny versicolor fungal infection. which is more of fine scale, lighter or darker patches. Treatment of acanthosis nigricans is urea creams, 20 to 40% creams, or lactic acid lotions, 12% lotions. It improves condition in 8 weeks. And topical retinol is also used around 12 weeks for visible changes. Thank you for your interest. Thank you for watching. If you like my videos, please thumbs up. If you like my channel, please subscribe. Thank you very much. Bye for now.